The Agenda with Steve Paikin is made possible through generous philanthropic contributions from viewers like you. Thank you for supporting TVO's journalism.
House calls mean something completely new in this era of COVID-19. With doctors and patients both learning to maneuver in a virtual healthcare setting, tonight we're asking, is this brand of medicine here to stay? Then, as our mental health care system struggles to keep up with the needs of patients, Dr. David Goldbloom will discuss solutions to meet that challenge. It's Tuesday, May the 4th, and that's next on The Agenda. Necessity has been the mother of invention throughout this pandemic, and in the field of healthcare, that has meant a shift to virtual medicine, the likes of which had apparently been impossible until it wasn't. Now that we've got it, will it change healthcare forever? Let's ask. In Yellowknife, Northwest Territories, Dr. Ewan Affleck, informatician with the College of Physicians and Surgeons of Alberta and co-chair of the Canadian Medical Association Virtual Care Task Force. In Fredericton, New Brunswick, Dr. Ann Collins, president of the Canadian Medical Association and a family medicine practitioner. And in London, Ontario, Dr. Keith Thompson, a family physician who also teaches in the Department of Family Medicine at Western University. And we are glad to have you three with us on TVO tonight from relatively near to very, very far away. You might be our first NWT guest, Dr. Affleck, so we're going to put you to work right away. And my first question is a bit of a quirky one, but I've never heard this title before. What's an informatician?
It's a good question. So, yeah, and it's not, I think you're not unusual in not understanding the term. So, a health informatician is someone who designs health systems for healthcare purposes to promote quality of care. So very simply, Steve, health information is essential basically to every decision we make in healthcare. And so if the integrity of that information is poorly designed, then the likelihood of quality care decreases. So guys like me help do that.
Okay, with that in place, when you talk about virtual care, what specifically are you referring to?
And that's, again, an important question because we've suffered in the health industry with a lack of consistency of definitions. So virtual care is basically care that is provided through any variety of technologies that is over distance. There's a distance between the provider and the recipient of care, the patient or the beneficiary of care. But it doesn't have to be traditionally like a physician and a patient. It can be any member of a circle of care, a speech language pathologist, or even caregivers, family members, or other people who are in the patient's circle of care. So that's what virtual care is.
Apologies. Dr. Collins, what had to happen for doctors in this province, for example, to be able to get themselves up and going online?
Well, unfortunately, Steve, it was a pandemic. Once the virus came into our lives, and as you know, last March, we were essentially put into a lockdown across the country. Physicians and patients could no longer come together in many instances in a face-to-face meeting or in-person meeting, in part due to public health guidelines about reducing the potential for transmission of the virus, but also a key player at that time was the lack of ability or resourcing for clinicians like myself in a solo family practice to be able to access PPE.
So all it took was a once-in-a-century global pandemic to sort of urge the people who run the government of Ontario to reconsider this. Is that all?
Well, we know that virtual care was around long before the pandemic. In fact, some would say that in Canada we were lagging behind in how we utilized virtual care in the provision of care. But absolutely, the critical turning point was the arrival of the pandemic.
Okay, Dr. Thompson, for a family doc like you, what does using virtual care allow you to do better now that you couldn't do before?
Well, certainly there's a couple of things, Steve. The convenience factor for patients, I think, is important, and that was a key thing I've noticed in the engagement. Also, the method by which we engage, those of us leveraging our electronic medical records and have spent time collecting emails or means of communicating with our patients other than telephone or video. I, for example, and some of my colleagues have been able to send via an email or text a link to materials, to educate patients or inform them, link in lab results, et cetera, that we can send to the patients and sort of make them part of that process, learning about their disease, right? So they're kind of included, they're collaborative in their care. And I think that's improved with the leveraging of all these technologies.
So do I infer from that that you're a big fan of this?
I really am. And I'll say, listen, for me as a primary care and fee-for-service guy, I got to say the announcement of these fee codes March 16th with the Ministry of Health was a lifeline. I mean, I literally could not have survived because I'm only paid when I see patients, and that was face-to-face. We were doing a little bit of video encounter using the OTN network, but it was clunky and it wasn't kind of a seamless workflow. And I think we're still struggling with that, right? And what this is going to look like going forward. But yeah, certainly I love it. The majority of my patients love it. They're really grateful not to have to come to the office and take for a 10 or 15-minute chat on a lab result, for example. Why can't that be done by telephone, text message, et cetera? So yeah.
Well, I think we have some empirical information here that actually buttresses the argument you just made. Abacus Data is a public opinion and research firm, and they did a nationwide survey of 1,800 Canadians last May. So we're going back to 2020 now. This is 2 months into the pandemic shutdown. And the question was, what do Canadians think about virtual healthcare? And here's what, Tony, why don't we put these numbers up? Thanks. Those who connected with their doctor virtually during COVID-19 reported a 91% satisfaction rate. 46% would prefer a virtual method as a first point of contact with their doctor. 45% believed virtual care could improve access to specialists. And 41% believe virtual care could improve the timeliness of test results. Okay, Dr. Collins, clearly some enthusiasm there on behalf of the people of Canada for those surveyed. Your membership, have they been equally as enthusiastic?
I would say yes. We know that from our response, from our survey of our members, that they have seen patient satisfaction, and they too are satisfied, knowing though that there still have to be in many parts of the country some improvements made in how we use virtual care and how we can deliver virtual care. But as Dr. Thompson alluded to be able to have that contact with your patients in a time when other contact was risky or just not possible, we've seen huge uptake primarily with primary care physicians, but it's also been interesting to see how specialists have also tapped into this and used it to provide access for consultation services.
Now, Dr. Affleck, I presume virtual care is an option that means one thing when you're talking about people who live in a city as densely populated as Toronto, for example. But in remote communities and the places that you serve in the Northwest Territories, is it a whole other ball of wax?
Yeah, yes and no. I mean, the value of virtual care, certainly for remote and people, Canadians in remote and rural locations, is self-evident. I mean, there's huge inequities in care for certain people. They do not have access to all kinds of services readily in their communities, and some of those services can be virtualized. So the argument is manifest that there is value in virtualization of services. And despite that, we've, as Anna said, virtualization has been around for a long time. The capacity, the technologies are there, and yet as a nation, we've been quite slow to adopt this. But there are arguments for virtualization both in urban and rural and remote places that are very just. You have to use clinical discretion to establish when it is appropriate to use. It's not a panacea, and but this differs depending on location.
Well, let me follow up with Dr. Thompson on that issue of hesitancy and why, for example, provincial governments have been resistant to bring this in. What's been the hesitation, do you think?
I think there could be a couple of layers to that, Steve. Certainly, one of the concerns would be utilization. And one of the dangers always in opening up these technologies and the ease of access. For patients, there's that push for the convenience factor. And for us as primary care, we want that continuity of care. We want that continuous story. But there is a danger, right, that we can just gamify, if I can use that expression, this technology. Dare I pick on my colleagues, certainly prescribing methadone, but we saw where a physician service providing methadone just became really a cash cow and not serving any other need. And I think we always have to be careful as we study this going forward that we don't want to be using this excessively just because it's easy. For example, I start renewing every patient's drug refill and engaging them by telephone or text and billing for that encounter, which I may not have done when that fee service wasn't available. So I think that's maybe part of the hesitancy. The other certain aspect would be that quality of care. So, we're studying, just to clarify, I'm not teaching faculty, I'm adjunct faculty at Western, but involved in some research under Dr. Bridget Ryan. And going forward, we hope to look at that hybrid model. So what type of things can we encounter safely? What are those issues, right, that can be seen virtually or maybe a simple text message? And what's that going to look like? And so that could be, again, where the ministry is holding back and saying, can quality be maintained or safety be maintained using these technologies? For sure.
Well, to that end, Dr. Collins, do you think there is a concern of virtual care being seen as somehow the default kind of care that is provided, and doctors in the future might only actually see their patients in person on rarer occasions?
Well, certainly, Steve, CMA's view on that is that virtual care is never meant to replace in-person care. It's meant to be complementary, and ideally it should be used where there is an established doctor-patient relationship. Certainly, I think that you make a good point. And we are only going to see an explosion of further devices, artificial intelligence, other adjuncts to virtual care that will be able to expand its use. But no, at the end of the day, when a person presents with a problem and you can manage it so far, perhaps with virtual care, there should be someone at the end of that care relationship that can actually see the patient. There are times when you know that you're not making the mark, you're not hitting the mark, you're not knowing what's wrong with this patient. You have to see them, you have to bring them in, you have to touch them, you have to lay your hands on. And of course, there are many other things that we currently provide as services in primary care, like immunizations and other screening procedures that need to be done in person with contact.
Dr. Affleck, let me try this with you. Are there safety concerns around the use of virtual care?
In short, yes, Steve, there are safety concerns. And there's safety concerns with any use of technology in healthcare. So we have to be very prudent with that. A very simple way to look at it is that a lot of issues happen between the interface in care. So if you see your family doctor and they refer you to a specialist, or if you're seeing a rehab person or you're going for surgery, the interface between those services, if information is lost, if lab results are lost, x-rays, whatever, communication of any sort is lost, then the individual caring for you will have less information on which to adjudicate your care, and potentially errors can be made, or your care may just be, you will not get the follow-up you require, right, for something that is time sensitive. So virtual care by definition involves the use of information, or the transmission, exchange of information between services and individuals. And so we have to ensure that that occurs in a way that assures the integrity of the information. Otherwise, it can be unsafe. And I will just finish this statement by saying there's not a long tradition of evaluating the safety of these technologies. We evaluate them with respect to privacy and security, but not safety. So this is something as a collective in Canada we need to begin addressing.
Let me follow up with Dr. Thompson on that. Are you concerned that virtual care opens the door for more examples of misdiagnosis?
I think there is that potential. I think part of what's being discussed here, and certainly Anne referenced this, and Ewan as well, is that these technologies work best in existing relationships. So, we have the advantage of knowing our patients well, but certainly we need the whole story. And so one of the dangers is if there's episodic care, whether it's virtual or face-to-face for that matter, at a walk-in clinic, not having the full background on the patient can really pose some serious issues. So, this will be the challenge going forward, is the types of clinical encounters we have, or the types of problems. For example, acute chest pain, not appropriate, right? As it might be a triage encounter that you have, but really that person needs to be seen urgently at hospital. I do know of one case apparently that went off the rails. It was apparently a pancreatitis. Patient presented with abdominal pain. It was a virtual encounter, and the physician was found, unfortunately, to be responsible for not managing that appropriately. It was disciplined. It should have been triaged to the hospital. Now, that being said, that's a diagnosis you could miss in your office and putting hands on the abdomen and feeling. So, part of this involves what sort of relationship we have with the patients. They have to trust us that we're doing the best for them, but we also have to make sure that if we're thinking of a more serious diagnosis, what's the best way to triage and deal with this, right? And it may mean disengaging from the virtual and going to a deeper encounter that's going to be a face-to-face in hospital or in clinic.
Well, Dr. Collins, if you don't mind, I'm going to ask you a few personal questions here, because I know you're here representing Canada's doctors, but this is not merely an academic exercise for you. How's your mom?
My mom's great. Thanks, Steve.
How old is your mom?
My mom is 89, and she's given me permission to release that information. And she lives in rural New Brunswick.
And she has used virtual medicine?
She has. In fact, probably her last 3 encounters with her family physician, who is located about 70 kilometers from where my mom lives, have gone very well. They've been both satisfying to my mom, and her physician, who is a colleague, feels that she's been able to provide the care that mom needs. And that's been really critical.
Don't take this the wrong way, but 89 years old is an interesting time at life to start trying something radically new as it relates to your health care. So how tough was the transition for her to accept this new way of dealing with her doctor?
Not at all, really, because of the distance from which she lives from her family physician. She, of course, or shouldn't say of course, but currently she no longer drives. So she relies on a family member, my brother, her caretaker, to take time away from work to bring her in to Fredericton to see her family physician when that is needed. So in those 3 instances, that was all avoided. They avoided some travel over not so great roads in the wintertime. Wintertime in New Brunswick can be hard. She is reassured that she has an upcoming face-to-face visit because she still likes that. That's still important to her. But otherwise, she's been quite satisfied with this type of encounter.
And again, I don't want to make any generalizations here. Some people, regardless of age, are whizzes at computers, and some people, regardless of age, myself included, are not. So has she had any difficulty as an 89-year-old doing whatever it is you have to do to log on, to link in, to make that virtual appointment work for her if she does do it on a computer?
So I think you've brought to the discussion a really important point. What we do know is that most, or many, I should say, and I think it's probably jurisdictional, many physicians and their patients continue to use phone only as a means of connecting. And in my mother's case, that was the situation. She would not likely be able to manage that on her own. She would need some intervention from again, my brother, her caretaker, to do that. But I think that highlights on both sides of the story that not all physicians are yet comfortable using a visual aspect to virtual care. Clearly, at this panel, that's not the case, but we know that phone is still the primary way of connecting in many parts of the country. And also, when we speak about not just seniors, there are others who maybe don't have access. We all think we have a computer or a phone. That's not the case. Or to have that digi knowledge to connect both audio and visually. So that also then points out another area where we still have work to do to deliver good virtual care.
All right, that takes me to Dr. Thompson next, because you've hit on a really important subject here, and that is, of course, in Canada, a lot of people get very squeamish when they think there is anything inequitable in the healthcare system. It's surely in politics, it's one of the third rails of politics in this country. So, Dr. Thompson, I'd like to know what discussions are going on right now about creating a system that will ensure that virtual care is equitable, regardless of where you live, regardless of how much bandwidth you've got, et cetera, et cetera.
Yeah, excellent question, Steve. And, I'm speaking to you here today in London from Anishinaabe, Lapénawa, Haudenosaunee, and Attawandaron, First Nations land. So acknowledging that, that is one area here at Western we're interested in researching further. And how do we keep access equitable? There's already inequity within the system, certainly regionally, because of some, issues. It's healthcare resource, it's the manpower, it's the staffing. And so, if we think of good innovation as being customer discovery, I think one of the things we need to be careful about is the customer is the patient. There's also the physician who is a user, but we need to, I think, go outside of our comfort zone a bit. And those people that are marginalized, right? We need to ask them, what are your needs? And so I think the approach that is being discussed now is getting deeper into that territory and saying, how can we serve you? How can we work with you? What are your needs? Rather than opening a laptop and laying it on the table in front of them and saying, here, we'll show you how to use this. No, we want to make them partners in this process. Equitable access in terms of, the use of the technology. So people with disabilities of some sort are challenged in many ways. How is this technology user-friendly to them? And if we have people, patients, that are housing deprived, that are on the street, literally, what is a value of them? There's a really neat program by Veterans Hospital, which has used social Sherpas, people that have been through trauma themselves and trained in the social system. And they come alongside with their tablet in hand, going street side beside the people they're befriending and are building trust. Hey, do you want to talk to my nurse Sally? She's on the line, and trying to pull them in right into the resources that maybe would help them. So I think equity, when we talk about equity, yes, it's certainly healthcare, but Steve, it's not just access to care that determines good outcome. There's social determinants. And even World Health Organization is looking at this. They talk about the digital literacy, but certainly digital determinants of health. And that's going to be a big part of how this moves forward. What's the line to connect to these people? But more importantly, how do we build that social infrastructure to support them just beyond even the healthcare alone?
Sure. I do want to circle back to something Dr. Affleck mentioned a few moments ago, and that is the issue of security. What security concerns do you have about virtual medicine, Dr. Affleck?
The security concerns for virtual care are not really unique to virtual care as such. It's all digital health or all health service. We have to assure the privacy and security of patient information, irrespective of the technology, whether it's paper-based or a digital technology that is in use. And this is a way in which Canada has not lagged as much. There are information and privacy commissioners in each jurisdiction. And so if anyone is deploying technologies, they need to complete what is called a privacy impact assessment, and they need to assure that their technology adheres to certain standards of privacy and security. But then with virtualization, there are other considerations. You're chatting with people in in non-traditional environments, like not waiting and not examining rooms, and you have to be aware. The same thing in your industry, Steve. You've had doubtless that we've all seen examples of people on the air and live, and their kid runs behind, or someone's coming out of the shower or something during the time of COVID. So all of these considerations need to come in with virtualization, particularly when you're using video. But as Anne said, the movement to virtualization in Canada has largely been phone care, and we're not we have not adapted significantly to many other virtual technologies. So there's a lot of upstream work to be done to actually coherently design an integrated virtual care service for Canadians. We've really just touched the surface here.
In which case, Dr. Collins, you heard a good list there of concerns about security. Do you think there's anything on that list that is so problematic that it can't be resolved?
No, I don't. People will become, from the other side of the chair, the patient chair, if you will. We've had conversations. I've had conversations when I was using virtual care where patients were in, a lineup at a coffee shop. Some of that is on the patient. They may, they accept that they are in a non-secure, non-confidential environment. But virtual care is still, in many ways, in its infancy, maybe moving into toddlership. And so patients will adapt to that. They'll accept what they're willing to accept. And I do believe that with the advancement of technologies, with the advancement of education, the CMA had just come out with a task force report just before this explosion of virtual care. Dr. Affleck, as you know, was very much a part of that. And so that work was just beginning. That work is going to continue, and these issues will be addressed. I think that they can be overcome.
Okay. Dr. Thompson, I don't know this for sure, but I'm going to guess that when you first broke into medicine, maybe 90% of your work was person to person, maybe the odd bit of stuff on the phone, but now with the pandemic, I don't know. Are you closer to 50-50 now or what?
I would say right now we're in a bit of a hot zone here in London. So we were starting to open up, but right now, Steve, we're certainly probably 80% virtual, telephone, video, patients sending me a picture on the platform of their rash, et cetera. So just a small percentage that would be required face-to-face, baby exams, immunizations, et cetera.
And is there a target here?
I would say there's the patient probably helps determine that. I have obviously my agenda and what I feel needs to be seen based on good clinical care, but the patients, I think, determine that as well. What I'm interested in, and certainly fascinating, Ian McWhinney, one of our founding fathers of family medicine here in London, talked about the reasons patients engage with us, and it's their limit of tolerance, the pain, the symptom, they just can't stand it anymore. It's their limit of anxiety. They're so worried. It's the ticket in. They come in wanting to talk about their smoking, but really there's another issue behind that they're concerned about, or it's administrative duties. So those driving forces are still there, whether it's virtual or face-to-face. And I've had patients say to me, oh, doc, I really want to see you. And I might not think it's a significant issue, but they need that contact. There's a healing aspect there that maybe, again, we have to be cognizant of that might not be addressed virtually. And I think that's kind of what determines how we engage.
And just to be absolutely clear here, if a patient says to you, doc, I know you think you can handle this virtually, but I really need to see you, you will see that patient?
Absolutely. I'm going to do my best and within the safety guidelines and infection control, which is definitely slowing down our day-to-day workflow in the office. But yeah, absolutely.
Okay. Just a few minutes to go here. And Dr. Collins, let me get you on this. Everybody, we've done this program, I guess this focus on virtual medicine a few times since this pandemic hit. And I always like to ask this question at the end because, of course, the pandemic, as you've all indicated, has allowed the possibility of virtual medicine to become a bigger part of the healthcare system. But then the question becomes, once the pandemic is over, and God willing, someday it will be, does everything go back to the way it was? What do you think?
No, I do believe that there will always be an element of virtual care. there needs to be firming up of the policies around payment and that type of thing, which I know many different jurisdictions are working on in terms of fee codes and expectations and so on. But there's been such a high degree of satisfaction expressed by both physicians and patients. Plus, it has allowed easier access to care in many instances, and access to care is a critical component of the doctor-patient relationship. So no, I don't foresee going back to solely in-person visits with full waiting rooms at all.
Dr. Affleck, virtual care here to stay?
Absolutely, I hope so. I've been working in this domain for 25 years. I was like the Maytag repairman, right? And nothing was happening until one day a little virus came along and suddenly everyone was phoning. So I hope it is here to stay. There are really, the fundamental question is, does this improve the quality of care for Canadians? And I don't think there's any doubt. There are multiple use cases when virtualization of services improves people's care.
Well, that's one of the key questions. The other key question is whether or not it can help bend the cost curve. Is this a potential way to more effectively spend money in the healthcare system?
Yeah, and the interesting thing about bending a cost curve in healthcare, there's a saying that is quality cures cost. If you just try to save money in healthcare by cutting services or cutting resources or whatever, you usually promote poorer outcomes, and then long term you'll promote greater cost. So the way to decrease the cost curve is to ensure improved quality of care. And so that is the fundamental question here. Does this improve quality of care? I mean, if you just look at Canada's north, Keith was mentioning, someone with a heart attack a little while ago, or someone with that in downtown Toronto, you would probably want to get them to be seen immediately in the emergency room. Well, in some remote place in northern Canada where they have to fly out and it maybe take 20 hours to get them there, you can use virtual care to mitigate that care. So if you look at the cost of transportation in the north or remote and rural Canada, you can offset costs substantially by providing services virtually that you otherwise couldn't.
Gotcha.
So
I'm jumping in there. Forgive me, Dr. Affleck. That's our time. I do want to thank all three doctors, you and Affleck, Ann Collins, and Keith Thompson, for coming on to TVO tonight. And we'll now let you get back to what you three all do so well, which is help people stay healthy. Thanks, everybody.
Thank you.
Thank you so much.
People coping with mental illness often encounter serious obstacles to accessing the right treatment in a timely fashion. Longtime mental health leader Dr. David Goldbloom knows that problem better than most, and his new book offers solutions. It's called We Can Do Better: Urgent Innovations to Improve Mental Health Access and Care. He is Senior Medical Advisor at CAMH, the Center for Addiction and Mental Health, and a Professor of Psychiatry at the University of Toronto, and he joins us now from what looks like an incredibly beautiful office somewhere in, where are you anyway, Dr. Goldbloom?
I'm in my bat cave in Midtown Toronto, where
Perfect.
I've been for much of the last year and a bit.
I certainly get that. Now, just before we dive in here, it occurred to me that there are actually 4 different ways of saying the title of your book. We can do better, we can do better, we can do better, or we can do better. And they all mean, I think, something subtly different. Where do you think the emphasis should be in that title?
I actually think it goes on all 4 words. And let me explain why I think that's the case. There's a very funny video clip of different actors saying to be or not to be. Famous actors who've all played Hamlet. And each of them emphasizes a different word and the meaning shifts. But I would put the emphasis on we, because this is indeed about all of us. Can, because it's feasible, and that should inspire hope. Do, because action is involved. And better is because the status quo is unacceptable. So without wishing to dodge your question, Steve, the emphasis is on all four words.
No, I think that makes a lot of sense. Now, I do want to take you back just briefly. About 8 years ago, we did a number of programs down at the Mars Discovery District in downtown Toronto, featuring award-winning innovations that were coming out of the mental health sector. And many of those innovations are in your book. You do talk about them, and the young scientists that we featured then are now leaders in their respective fields. But after 8 years, apparently these treatments are still not really very widespread in their use. And I wonder if you have a theory as to why that is.
Well, there's evidence that the timeline from discovery and innovation to implementation throughout healthcare can be as long as 17 years, which seems unfathomable, except that I would say, number one, old habits die hard. And for all of us as healthcare providers, we learn to do things a certain way, and then we get into our clinical routines, and learning to do things a very different way or think about things a different way is a challenge for all of us. The difference now, I think, is that in the context of the pandemic and the emergence of a vaccine within months, whereas the previous record for vaccine development was, I think, 8 years for mumps. There is an expectation, I think, in the general public that we need to do things faster. And I think one of the benefits, if you're looking for silver linings around the horror of the pandemic, is that the public is going to turn up the heat on expecting better things.
Do you not find it passing strange, though, that there are other countries in the world that are using our techniques more broadly than even we are?
Yeah, it is always a little strange, but my experience of going to other countries is that there are things we're doing in Canada that they're envious of, and we're envious of things going on elsewhere. So, it all comes out in the wash, I guess, but when you're living here and looking at the landscape internationally, you do ask, well, why can't we do that here?
Let's dive in and read an excerpt of the book now as we continue our conversation, and I'll ask Tony Burke, who's helping us out today with the buttons, to put up this excerpt. Currently, you write, there is little logic in who gets what kind of help. It can be more a reflection of where you live, how much money you have, or who you know. Some people end up getting no help at all, while others used highly specialized resources when a simpler intervention could work. In fact, this isn't just an issue for mental health care, it's about how we approach health in general. You point out that we seem to be stuck in a model of mental health care delivery where people may be, for example, treated for a longer period of time than they need to be. Why does that happen?
Well, I think it happens because people get into a groove. Let me be clear. There are some people who do need long-term treatment, and I would include some of my patients in that cluster of people who need long-term treatment, who are dealing with chronic illness, and for whom a brief intervention is not going to make a difference. But there's also the reality that we get comfortable in our relationships with our patients and vice versa. And that may lead to a continuation of treatment when people are already on the flatter part of the curve, that the initial benefits have been a steep rise and then things continue. And when that happens, there are opportunity costs. And the opportunity costs are, given the finite number of providers we have, that there are other people on the outside who are not getting in.
Do you think that most of your colleagues know when shorter term treatment is preferable?
I think so. And I think that there has been a push to recognize our responsibility to meet need. The need is so palpable, and the calling out for help so much more public and loud than it used to be. But I think most people have a real sense of urgency as clinicians about trying to help people as many people as possible, and also looking at what's the shorter term intervention I can do that will make a palpable difference.
We know, even before the pandemic started, of course, that depression was far too pervasive in our society, and it has only gotten worse during the course of the last 14 months. There are many medications to treat it, but finding sort of the right mix for the right people at the right time has always proved problematic for many, many people. Are we getting better at that?
I think we're getting better, although we have not eliminated the trial and error that governs our selection, for instance, of an antidepressant. We try to predict based on side effects profile or whether that person has benefited previously from a particular antidepressant or someone else in their family has. But I think one of the newer innovations has been the use of pharmacogenetics, which is looking at people's genetic profiles and trying to figure out from that which antidepressant they might best tolerate or respond to, and thus maybe eliminate some of the steps in the process and some of the cost and some of the delay and some of the suffering.
Understood. Let's pluck another excerpt out of the book, and I'll get you to comment on this as well. Tony, if you would. Clinicians are very good at providing service to the people who come to see them, but less good at thinking about the people who don't come and why they aren't seen. That makes sense, you write. As clinicians, our first priority is understandably the person sitting in front of us in our offices and clinics, not the invisible person who hasn't found the right door to enter. Okay, all well and good, but how does your profession begin to think more effectively about that person who hasn't figured out yet how to get into that door?
Right, and this is what I was referring to earlier in terms of opportunity costs, in terms of people not getting access. And there are a number of ways that we can create more doors, and some of them are physical and some of them are virtual. In terms of physical doors, one of the striking changes over the last several years in Canada has been the emergence of integrated youth services. We're all too familiar with the delays that a number of young people face in accessing mental health care. And, when those delays are measured in months or even years against the denominator of how young someone is, they really become unconscionable delays. The development of integrated youth services that are community-based, that are not appointment-based, that are walk-in, that are places where your initial assessment happens not within months, but within hours, means that you're going to be able to reach a lot of young people who previously might not have been engaged by the traditional system. And we already have evidence emerging from the research being done in Canada that we're reaching some of those youth who might otherwise feel marginalized or excluded. So that's a physical example, but then there's the virtual world. And again, the heat was turned up by COVID. And making healthcare available virtually in a meaningful way is part of that solution as well.
Let me follow up on this angle of younger people and how they can get in, because, of course, far too many of them end up getting into the system because they're in crisis and they end up going to an emergency department at a hospital. You've got an example in your book where you talk about an organization called SFI, the Strongest Families Institute, which is in Nova Scotia. Maybe you could help us understand how they go about treating kids.
Well, one of the great things about the Strongest Families Institute, which has been around for a while, is that it's a telephone-based service, that it uses counselors who are not from the traditional stock of counselors. They're people often with an undergraduate degree who are carefully coached, trained, and supervised to deliver care to entire families, and they really deliver it from a call center, and they deliver it in the evenings when families are most likely to be together, which is a significant shift from the 9 to 5 weekday world of mental health care delivery that is focused much more on a patient and family centered perspective. And they can make a real difference working with families of young children with attentional problems, behavioral problems, working with the whole family in the evenings and via something as technologically low tech as a telephone.
Let me bring you back to the province of Ontario. How well do you think we do here at dealing with this age of clientele?
Well, you'd be better to ask the parents of kids who are struggling, and they will tell you not well enough, not good enough. And we've got some significant family organizations who've been beating the drum appropriately to try to raise more attention, more funding, more resource so that young people get the help they need. So there is fortunately huge room for growth, although that's also unfortunate.
I don't know if there's a turf war going on here, but maybe you can help us understand that. Because, of course, if you need mental health services, there are social workers, there are psychologists, there are family doctors, not just people who are, if I can put it this way, at the top of the food chain, which is where you are. And I wonder whether your profession is at the point where it's prepared to sort of loosen the reins enough to ensure that there is a broader role for more people who can provide more help.
If we look at some of the most successful interventions around improving access to help, it's often been by creating a whole new cadre of mental health providers. The huge experiment in England to improve access to psychological therapies didn't rely on traditional resources, but trained up a whole new group of people in very specific psychotherapy skills and made those resources available to the public. In terms of guild concerns, that somehow we would be losing patients or clients, there is so much work to go around. Nobody is going to go hungry looking for people to help.
Can I just do a follow-up on the UK example, because that's interesting. I learned from your book that you don't need a referral from a general practitioner to get into the system in the UK. You can refer yourself. How does that work? Because I guess it's different from the way we do it here.
It's very different. I mean, our system traditionally, in terms of access to publicly funded care, and I want to emphasize that the improving access to psychological therapies in the UK is publicly funded through the National Health Service. In Canada, if you want to go that route, you typically go through your family physician or nurse practitioner who is the quarterback overseeing your health. So this was a big shift to do this the way they did it in the UK, but it has worked out very well. And the people who self-refer are people who are genuinely in need. We have, the beginnings of some of that in Canada. Right now in Ontario, Ontarians can self-refer for web-delivered therapist-guided cognitive behavioral therapy, which the province has made available for free to citizens of Ontario.
How effective do you think that is, particularly at a time where many of us are not really allowed out of the house these days?
Well, the beauty of doing it is it's all done through your computer. So if you were looking for an intervention that was tailored to the restrictions of the pandemic, it would in fact be internet delivered cognitive behavioral therapy. And in terms of effectiveness, recent studies in the literature have shown that it is as effective as our traditional face-to-face delivered cognitive behavioral therapy.
Let's go a little further down this road here. Mental health apps, how effective can they be?
Well, the apps world is exploding. And one of the beauties of apps is that as opposed to your therapist, they're always available. And when you use them, they're always thinking about you and responding to you. A number of apps have been developed in India, in the United States, and also in Canada to try to improve access to some pretty fundamental psychotherapy. And one of the things that's striking about some of these apps is that they leverage the power of artificial intelligence so that the apps learn about you and also remember things about you that some of us humans might otherwise forget from time to time. So I think that there is huge potential here. The evaluation of apps has lagged behind their development and dissemination, and there's a bit of catch-up going on. And understandably, there are also concerns about privacy that need to be addressed with the use of apps, as we belatedly discovered with Facebook and other forms of online interaction.
I bet, though, that when you got into this profession, however many years ago it was, you probably said to yourself at the time, at least thankfully, I'm in one of those professions that will never be replaced by artificial intelligence or machines, because after all, what I do is so utterly personal and unique in each case, you could never be replaced in that way. That may not be true anymore. Is that fair to say?
I don't think that is fair to say. I think what happens is it will redefine what we do at a human level. And, there have been all kinds of innovations throughout healthcare where machines can do things that humans used to have to do. Electrocardiograms that measure your heart rhythm used to be simply a printout that a human had to interpret. Now, the printout comes with an interpretation, but then the human cardiologist reading that interpretation has to apply it to the backdrop of the individual and the physical exam and the clinical reality. So these are tools that allow us to be, I think, a little more refined in what we do as humans. They don't replace us.
All right. In our last few moments here, let's look very specifically at the pandemic. We are learning all sorts of new things about the kinds of mental health treatments that are possible during the course of a pandemic that we might not have discovered had this not happened. I wonder how you think in the long run it will affect or change the mental health care system in this province, and how it will deal with our needs going forward.
Well, look, one of the big changes for me as a psychiatrist is working virtually for the last 15 months through televideo. And I used to do a lot of televideo to Northern Ontario, but now I'm doing it to downtown Toronto. And it is for patients often a very positive experience, and we have survey data that shows that. But it's also about bringing care to people's homes rather than putting the onus on them to come downtown or to travel or to get childcare or to take time off work. So in that respect, it can be a lot more patient-centered, and the government moved to fund it so that people like me are paid for providing this kind of work. I think post-pandemic, this kind of virtual care is here to stay in the menu of options about how people choose to get help.
Well, that's the key question, isn't it? Because in my conversations with people inside OHIP in the past, they've always been leery about giving doctors this right to treat virtually because they were never, let's be blunt, they were never really sure about how much fraud would go on in the system and paying doctors for things that never actually happened because there was no example of a patient walking through the front door of a clinic. How sure are you that, in fact, this new option of virtual care is going to stick around post-pandemic?
Well, Look, I'm not the guy pulling the levers within the government on this, but I think that there is huge public appetite for it that didn't exist previously. And as for fraud, frankly, you still have to write a note on your patient, and people can ask for those notes, and they can interview people and say, did you see Dr. Goldbloom on this day? And they used to do that when it was in-person visits as well. Fraudsters will always find a way. But honestly, I don't think my colleagues are fraudsters trying to bilk the system. We're just trying to bring care to people who are constrained by the exigencies of the pandemic.
In which case, let's finish up on this. Is it difficult to remain optimistic about what your profession can do in the face of incredibly trying times that people are living through right now?
No, it's not difficult. And I say that because I have the good fortune of knowing a lot of people in various mental health disciplines and how dedicated they are to providing people with the help they need. And we also get to see the rewards, right? We get to see people get better. And that is hugely motivating and galvanizing.
You know, I want to make sure I say the title of the book the way you said it when I asked you the very first question. So let me try saying, We Can Do Better. Emphasis on each individual word by David Goldbloom. Thanks a lot for coming onto the agenda tonight. So much good information in this book, and we're glad you wrote it.
Thank you so much, Steve.
And that is the agenda for Tuesday, May the 4th, 2021. Tomorrow, we'll look at the problem of declining male fertility and what's causing it. I'm Steve Paikin. Thanks for watching TVO, for joining us online at tvo.org, and we'll see you again tomorrow.
The Agenda with Steve Paikin is brought to you by viewers like you. Thank you.